It's been interesting times.
Okay.
So we have only next 20 seconds to go live. So we are ready. So once we are ready, just let me know. I'll give you a countdown and you'll be live. Should I give the countdown now or do we need to wait?
Yeah, I think.
You can count down.
Okay, be ready. 5, 4, 3, 2, and 1. You are live.
Greetings. Greetings on this Sunday morning, afternoon, or evening. It gives me great pleasure to welcome you to this webinar, to this little conference seminar on big ideas in trauma care. And today's topic is managing periprosthetic fractures. We have a great faculty from all through the Asia Pacific region and the UK, and we're very pleased to welcome all our guests who will be introduced individually in a short period of time. The big idea in trauma care is an Asia Pacific Orthopaedic Association educational strategy to provide a series of small webinars that allow our members and the broader orthopaedic community to participate and ask as many questions and learn from the many experts in the area. I'd like to thank the Asia Pacific Orthopaedic Association and, of course, our Secretary General, Jamal Ashraf, for all the work. He really powers through a lot of this work behind the scenes in a very quiet and methodic way. So I'd like to thank Jamal for all his effort, for all his time, and really for his support. As the president of the society, I'd like to now hand over to Azlina Abbas, who will start off the sessions and start introducing our great guests. So enjoy. Please feel free to hit the live chat button and send in your questions. And the order of events will be a series of talks followed by a question and answer session at the end. I look forward to some great learning. Welcome.
Thank you, Dr. Pirpiris. It is my pleasure to introduce Dr. Noratep, who is our first speaker today. Dr. Noratep is a young and dynamic trauma and arthroplasty surgeon working in Ramatipedi Hospital, Bangkok. He is a regular faculty in trauma conferences across the Asia-Pacific region. I now invite him to present his talk on periprosthetic fractures in a well-fixed stem of THR. The screen is yours.
Thank you. Okay, so my talk today is the periprosthetic fractures in a well-fixed stem of total hip replacement. So the outline of my talk will be first, how to evaluate the implant stability, which is, I think, is one of the most important part of my talk. The decision-making when we should fix it or do revision surgery, and how to create a stable fixation to obtain a good healing. And of course, the implant option that we had, and also the biomechanics study regarding to each implant. So we see the first case, 31 years old, sustained the motorcycle accident, just 31 years old. And this is second time, his second accident, his second major accident. I think the difficult part for us is, well, is it well fixed or loose? Because it leads us to different treatment categories. So we have to find out that it's loose or not at the beginning. So I think from my talk, the well-fixed stem is classified as Vancouver type B1. And of course, most of type C is also the well-fixed one too. So I will cover these two types. The important question for us when we see a well-fixed stem is it really stable? Sometimes we think it was stable one, but actually it's not. So how can we make sure that it's stable? And the second one, how can we fix the bones around the stem, which is a difficult part for us? The first question is the stem is really stable. I think we have to begin with history. Well, if the patient doesn't have pain on the hips and can walk very nice, we will call it a happy hips, and the stability seems to be okay. But if the patient had pain or some deterioration of the function prior to the fractures, as to be loosening or fractures with minimal trauma, we will call it an unhappy hips, and the stability is in concern. And after that, we have to take a look at the stem. It was a cementless or the cemented one. If it was a cementless stem, we have to classify by type of the stem. It was a proximal coated, fully coated, or the modular stems. And then we have to take a look at the fractures that it was involved the osseointegrated areas or not, because this is the place that provides stability for the implant. So for example, these two cases has a same stem design. On the left side, the fracture is not involved the osseointegrated area, so it's still stable and we can fix it because it was type B1. But on the right side is directly involved the osseointegrated area, so it loose already. Now we have to revise it because the stem is loose, they offset. And on the cemented stem, if you see one of these signs, which is a definite sign of loosening, well, you can proceed to the next lecture because it was a loosening one. But be careful that cemental fractures that happen by the periprosthetic fractures is not a definite sign of loosening. Personally, for the cemental in Vancouver type B1, I think it's like an ice cream cone, which is tightly attached to the bones around it. So when the bone is broken, of course, the cement was broken too. And if we able to reduce the bone back into the places, it's still able to hold an ice cream for us and we can fix it. So it's not a big problem if the cement was break from the fractures. And again, the serial radiograph is very important for all of cases because from the single spot X-ray, it's difficult for us to tell that it loose or not. For example, this is the case revision surgery, and this is the X-ray after immediate revision surgery, and this is the radiograph 6 months prior to the fractures. So you can see there is a cemental fractures here, and the straight fractures close to the tip of the stem. So this is a definite sign of loosening. So we have to find out in every cases. Dr. Curtin did the surgical dislocation in 45 cases who have been diagnosed with Vancouver type B1, and he found that 20% of the case have to be reclassified into a loosening one, into B2. So the question is, how can we improve the quality of diagnosis? Well, does the CT scan can help us? Well, many studies shows that the CT scan is not improve the quality of diagnosis on the implant stability. So we still cannot count on it. In case that you doubt about the stability, the intraoperative assessment, direct operative assessment, especially in type B1, going through the fractures and direct manipulate the distal part of the stem. So for the cemented stem, you have to see that there is a motion between the cemental and the bones or not. But for the cementless stem, you can direct manipulate the distal stem to see the motion between the implant and the bone. Many literature suggests us to do the open joint evaluation in all cases, but it had some drawback because it will impair the hip condition, soft tissue condition. So personally myself, I didn't do it every case. It's just only the case that I was doubt about its stability. So take a look at the case. The 78-year-old woman with end-stage renal disease, she received hemodialysis 3 times per day. And she told me that before she had the fractures, she can walk without any problem. So I classify her as a stable one, a happy hips, and she also had a happy knees too. This is the interprosthetic fractures indeed. Vancouver type B1. So the choice of treatment is fixation. So let's go through our second question. How can we fix the bone surround the stem? I think we have many options. We have cable, wiring, we have unicortical screw, monocortical screw, cable grips, locking attachment plate. So which one is the best option for us? I think we have to decide based on the biomechanics study. So they study comparing different type of fixation around the stem, and they found that using a screw fixed around the stem is stronger than using the cable alone. And the others two study comparing between the bicortical screw, whether insert through the locking attachment plate or insert by using oblique technique, comparing with the unicortical screw. And it found that the bicortical screw is stronger than the unicortical one. So in summary, the bicortical screw is stronger than the unicortical one, and the unicortical one is stronger than cable or wiring. But in real situation, I think we can combine these techniques together, but we have to know that which one is strongest. So in this case, I temporarily stabilize the fractures using the circlage wiring, and then I bridge the whole bone using proximal femoral LCP. To prevent any further fractures that may happen in the future. And then I secure the plate to the bone by using the conventional screw insert through the oblique technique, and then fill the remaining with the locking one. So this is 6 months after surgery, the fracture healed. Many surgeons afraid that the violation of the cementmental by the screws or the drill will lead to the premature loosening of the stem. And I try to search on the every literature, and I found no evidence that insert the screw to the cementmental will cause early loosening of the stem. So we still able to use and fix it. Next case, 49 years old with underlying SLE. She fell down from the floor and sustained left periprosthetic fractures. At the beginning, I saw this radiograph. I think that the hip position is still in a good position, and there is no radiolucent line between cementmental and the bone. However, she told me that she had pain for almost 6 months before she had fractures. And we know that the pain is not a good indicator because it may tell us that the implant may be loose or not. Well, who knows? But it's not a good indicator for us. So what I did is to the retrospective review since she had been operated since 2005. And what I found a very interesting things on the radiograph. So on the lateral cortex, I found a thickening at the lateral cortex of the femurs. And in 2015, here is the thickening of the lateral cortex. Can you see it? And in 2016, it's become more prominent. And then next year, a fracture does occur at this area. And of course, the fracture itself was crossing the fourth zone of the cement, which is the weight-bearing area of the cementmental, of the cemented implant. So this is not a good sign also, because we believe that if the fractures pass to this area, it may affect the longevities of the hip implant in the future. It may cause early loosening. So I discussed with my patient that, well, you may need to do revision surgeries or not. It may affect on the longevity, but he said that, okay, just fix it. That's it. I do the literature, I do the history review of his her current medication, and she has been treated with alendronate and prednisolone for around periods of time. So in this case, it was the periprosthetic typical femoral fracture. So the pain that she has is not caused from loosening, and it caused by a straight fractures. So I fixed the plate using the proximal femoral LCP. I prefer the long plate. I don't want any fractures in the future. So my question is this a balance fixation? Is it good enough? Well, what is the meaning of the balance fixation? We have two sides of the fractures. On the proximal part, I have a short lever arm with 4 unicortical screw and wire. And at the distal part, I have a long lever arm with 4 bicortical screw. Well, let's take a look at the result. In 2 months after surgery, we found some collapse. So even it was a typical femoral fractures, the biologic is still good. And at 6 months, the fracture is about to heal. However, at the proximal part, you can see that the screw was cut out from the bone, and the fixation was changed into varus position. So in this case, I have to revise the fracture, the fixation. Then I revise it with the broad curve LCP, so I can insert a smaller screw using the bicortical technique. I didn't open fracture site because the biology is good, and 6 months the fracture healed. So what we learned from this case, the pain is not always indicate that the stem is loose. We have to find out the other cause, for example, the straight fractures, the cancers, or the pain which may radiate from the back to the hips. And the balance fixation is very important to achieve a good bone healing. Otherwise, the weaker side might fail, and mostly it was the side which close to the stem. And the history and serial radiographs is very crucial for us. I do like this guideline because it helps us in cemented periprosthetic fractures. If you have the patient with a good bone stock, the question is, can you reduce the fractures? If you can reduce it, take a look at the cemental. If the cemental is still okay, you can fix it. That's it. But if the cemental had some fragment loss or mental deficiency, you have to consider to fix with the cement-on-cement revision surgery. But if you're not able to reduce the fractures back into the places, which means that your ice cream cone cannot reduce too, it's better to do revision surgery. Or if the fractures does occur at the tip of the stem, it's still advised to do revision surgery. Next case, 79 years old, fall down from the stair. At the beginning, I see at least 2 fractures. Firstly, I thought that it was a segmental fractures or not, but well, after I take a look at the fracture configuration, it's not effect on the osseointegrated area. So this is a stable fracture, stable implant, sorry. So I do the CT scan, not to evaluate the stability, but to see the fracture configuration, and I found a large butterfly fragment at the posterior medial aspect of the femurs. So first, I temporarily reduce this case using wiring, and then insert the longest distal femoral LCP to bridge along the femurs. For the fixation around the stem, in this case, I use the locking attachment plate. Personally, I think that it had some mismatch with the Asian bone, because the Asian bone is much smaller than the actual side of this implant. So I can insert just only 3 or 4 screws out of 8. However, if you place this implant in the good position, for example, close to the calcar area, you can get a long screw, which provide more stability for us. So this is the X-ray after reduction, and 66 months after surgery, the fracture healed, no problem. Next case, 52 years old, after hip revision surgery, she sustained the fractures close to the tip of the stem. And again, I think that with the revision cases, the previous radiograph is very important for us. This lady had pelvis fractures and loosening periprosthetic, loosening hip implant. So the surgeon did revision surgery with the fully cord stem. And during the surgery, there is an intraoperative fractures, and they reduce the fracture and maintain with wiring. And after that, you can see that there is a progressive more alignment of the femurs into varus position. And then the fractures. So the fracture is not involved the osseointegrated area again, because this was a fully coated and it happened very distal. So now I face 2 problems, progressive varus malalignment and also the fractures. So my decision is to do the lateral cosway osteotomy to realign the bone. So this is the X-ray after surgery, 10 months. You can see that the tip of the stem is now in the center of the femurs. So it will prevent the further straight fractures which might occur in the futures. So the fixation, I think that we have to also restore the mechanical axis during fixation. If the implant was placed in more position, even it's not loose, it's better to revise the implant, the hip implant, because it may lead to the failure of the construct later. And I also prefer using the bicortical screw even with this big implant. So for type C, I think I will go it very quick because it's just only single question that we need to answer ourselves, which is the appropriate plate length. Should we end it distal to the stem or overlap it? And again, I think the biomechanics studies can tell us if the most proximal screw was located from the tip of the stem around 8 centimeters, the strain is not much. But if the screw was closer and closer to the tip of the stem, the strain was getting higher and higher. And then if we overlap it, well, it will reduce again. So if we place the stem, we place the screw close to the stem like this, the fractures may occur in the future. So my preference is not 8 centimeters, but I prefer to overlap the plate. So in every cases, I will overlap the plate up above to prevent the fractures in the future. Okay, so in my conclusion, I think we have to classify the patient first. If they have the hips, well, we fix it. If it was an unhappy hips, we have to revision surgery. Intraoperative assessment is very crucial in the case that we doubt about the stability, and surgical dislocation might necessary. And the bicortical screw is my preferring option, but in the real situation, we mix it together. And in type C, I think we do advise to overlap the plate in all cases. This is the case that I brought up at first. I fixed this patient, the 31 years old guy, because the proximal part is still okay, is still intact, so it's still classified as type B1. However, after surgery, he disappeared from the hospital, so I didn't know the result of this case. Thank you.
Okay, thank you, Dr. Noratep, for a very instructive lecture. We have, I think, a couple of minutes just to answer some of the questions posted by our audience. Some of them have actually been answered by your talk, but there is one question here that, I think the audience would like to know. How difficult is it to insert a screw through a good cement metal, knowing that you need bicortical edges?
Yes, for the cement metal, I think that it's not difficult for us to insert a screw. Using the bicortical technique, the cemented stem itself is narrow comparing with the cementless one. So the cementless stem is much more difficult for us to insert the screw using the oblique technique because the stem itself is broader than the cemented. For the cemented stem, we can make a drill, and of course, after you pass through the bone, you will get another tough bone, which is a cement metal, and you can see from the drill that the cement metal, the cement itself is come out from the drill, and now you will know that okay, it's going through the cement metal, and then you will reach the far cortex, and then you can able to get a good strength, a pulley strength, which is better than the bone itself.
Okay. So that's why it's advisable even with cement.
Yes.
Okay. I think the last question we'll take for this talk would be, there's a patient with a liver transplant who has had a hip replacement 2 years prior, came with periprosthetic fracture. How easy is it to manage this type, and how would you manage this kind of cases?
The renal failure?
Liver transplant.
Liver transplant. Wow. Okay. I think that the most important part is the conditions of the patient. I don't know that the patient condition is good or not, because if we talk about the liver transplant, if it was success, the patient may need to get the immunosuppressive drug during after they get the liver transplant. So the only one of my concerns is about infection. Because it may increase the risk of infection. However, about the bone quality and the surgical technique, I think that most of the cases we have been expect that after the organ transplantation, the patient activity is not so active. The bone may be a little bit so fragile, and to achieve the good fixation, I think that we may need the options such as the locking attachment plate, so we can get many screws around the stem to prevent the cut out of the bone and the screw. And of course, I think the most important part is to evaluate the patient condition. That is the only one concern rather than the fractures.
Yeah, life before limb always. Okay, with that, thank you very much, Dr. Noratep. I'll hand over to Dr. Anup, our moderator for the next speaker, who will introduce the next speaker.
Thank you, Azlina.
Thank you.
We don't have Dhaval Desai yet to join. So I would request now Marinis to join us for this talk. And he's the chair of Orthopaedic Craft Group at Cabrini Hospital, Melbourne, Australia. He's the chair of Asia Pacific Trauma Society and also a member of governing body of APOA Trauma Asia Pacific. So I would request Marinis to start his talk. Maybe Dhaval will join later on, so we'll take his talk later on.
Okay. Thank you very much, Anup. Okay, so periprosthetic fractures in the femoral side of a knee replacement. So we've moved down a little bit, down the femur bone. And really, we're sort of going to talk about a treatment approach based on some biological fixation, the importance of reduction. I think Noratep mentioned a good point, which was alignment. And it's important that we reduce fractures and not just focus on minimally preserving procedures. And then perhaps a judicious use of megaprostheses. They're not that common, but they happen commonly in trauma hospitals. They may become more common with time as we have more and more people with joint replacement surgery surviving a longer and longer period of time. Overall, it's about 1%. And on the femoral side, it's about a third of those, depending. Now, the important thing to also remember, and I think Noratep touched upon it too with that significant medication list, is these patients are old. They're often immunosuppressed. They often have significant cardiac, neurological, immunosuppressive conditions, and they have significant amounts of osteopenia. And, you know, we always talk about the notching, and that's a technical issue that we talk about and whether it's related to fracture. But in actual fact, we really need to start treating these patients like they do in the United Kingdom now, as patients with fractured neck of femurs, with the aim being to have early surgery and to have early mobilization. And if possible, we should try and weight bear them as tolerated from day one. So that means we need to take care of business and do things well, set up constructs that can take them walking. In terms of the classifications, there are a number out there. This was the Louris and Rohrabeck, and really they relate to type 1 and type 2 fractures. And I think that most of us, unless the bone stock was pretty ordinary, in type 1 and 2, they almost always have fixation. It's the type 3 that we're really a little bit unsure about as to, when we see them on the x-rays, as to whether the component's loose. Because if the component's loose and the bone quality is very poor, then you may not be able to do what I asked of everyone earlier, which is to fix them and get them mobilizing very quickly. And you may need to think of other options, including the distal femoral replacement. And SU is the other one that's quite good, very similar in terms of their classifications. The non-operative approach. So when I first came back from fellowship 20 years ago, you know, we tried a few non-operative approaches, but I found, you know, having people non-weight bearing for a long period of time or having very old people weight bearing in a cast was really unsatisfactory. So unless the patient is imminently at risk of an anesthetic and expiring during the anesthetic, I think it gives you poorer outcomes on the whole, because it means prolonged bed rest, often with a whole number of complications. And I often saw a cognitive decline during that whole time, as well as depression and all the other functional deterioration that goes along with it. So when you see something like this, a 75-year-old, this is a pretty common case. It's a little comminuted at the fracture site. The bone, you know, we always talk about whether, if you, in the old days when you had an x-ray, whether you could actually see the bone on the x-ray, because it gives you some indication of the bone quality. And thank goodness that we have locking screw constructs. And I think locking screw constructs or angularly stable constructs with a biological approach to these fractures is probably the way to go. I think we've moved away from what happened 20 or 30 years ago, which was absolute stability, often not done very well, so that we had some relative instability, and then our constructs failed because we stripped the bone and we also made very stiff constructs that didn't stand the test of time. So when you are putting on some plates, and sometimes we see these in our clinics, and you know, people come along and they have a short plate, and then the storyline starts. You can see here that that plate's very short, and you know, and 15 or 20 years ago, if people hadn't read the work of Gautier, they may have started off with a shorter plate and thinking that that is probably sufficient. But in actual fact, I think the tone is now not only to reduce the fracture, but to go long and strong. So you try and disperse the force through the whole of the femur bone rather than in a very small section of the plate. And I think most of us that have done the AO courses will have done the skills courses that actually explain why it's, you know, stiff constructs with the stress concentration through a short period of the plate is not particularly good for the plate. So, you know, I think on the whole, we all agree that laterally based plates are probably the working horse. That's what most of us do. We often use them via minimally invasive or soft tissue preserving procedures, and we go long and strong. And sometimes we use intramedullary nails. And I still think there is a place for intramedullary nails in some of these fractures, and they're making a comeback. And I'll talk about nail plate constructs a little bit later in the talk. So it's not surprising then in very osteoporotic bone that, you know, the fracture seems to be holding up together, but then you can have some stress rises towards the top of the plate. There can be a fall, you know, and then all of a sudden you're left with trying to revise it to something. And you can revise it to a longer plate. I get that. And it's not an issue revising it to a longer plate as long as you go long and strong. But we thought revising it to a nail in this situation was good. With immediate weight bearing and you'll get callus formation because we haven't opened the fracture site. We've preserved the fracture site, and perhaps a little bit of internal reaming help provide some bone graft at that fracture site to heal. And it goes on to slowly heal with time. Yeah, the other thing I'd like to add is older people often, if they've had numerous surgeries, take a longer period of time to heal. And I find that older people that are on osteoporotic treatment also often take a little bit longer to heal. So don't expect them to heal in the same timelines as the younger person. They just take a little while longer to unite up. So, you know, when looking at list plates and retrograde nails for the fixation of periprosthetic fractures, you know, this is a lab model and they both have their place. You know, the nail probably has a greater resistance to varus load. The plate has a greater resistance to valgus load. And that makes sense because the plate is on the lateral side. So I don't think this was an enlightening paper. It just helped us to understand, as long as you can get fixation distally, how the nail may be useful. The other thing about plates and nails, because there was a real concern at one stage about metaphyseal non-union rates, is that when you look at them and you look at the loads, you can see the intramedullary nail and the bone mineral density and the load failure. You can see that as we move along, and there's a crossover point with the plates. And there is an issue perhaps with the older plates of them failing a little bit earlier. So here's another case. This is a little bit lower, fixed with a nail. Now, on the whole, the short nails are okay, but I prefer using the longer nails that go higher up. But the longer nails are a little bit more challenging, and I'll go through the issues that the box provides relating to more challenging nails. The shorter nails tend to be less challenging because you can make up for some of the offsets related to where the prosthesis sits on the bone, because the prosthesis often is not centralized in the bone and your starting point is not in the middle of the bone. So you just have to be wary of that and either make up for that with either a nail that has a little offset at the bottom, and there's not a lot of those around, or you need to accept the fact that you need to use a shorter nail if the nail's your implement of choice. And this is the challenge. The challenge is the lining up of the cruciate retaining prostheses. Obviously, in a posterior stabilized where there's a box, it's a little bit more of a challenge going through the box. In a cruciate retaining prosthesis, sometimes if it's not centralized, some of us will occasionally pull out the Midas Rex and try and rub off a little bit of it, but that's not a commonly used technique. So I would rather go for a plate rather than a nail, particularly if the component is not centralized with the anatomical axis of the bone. The other thing you need to be worried about is if you don't know the prosthesis, there is often a little flare of the nail, particularly as it gets to its most proximal aspect. So you need to use a nail that has a similar diameter all the way along, because you can get stuck if you're using a nail that doesn't quite fit through the box. So you have to do a little bit of homework, particularly if it's your first nailing case in a retrograde manner, to ensure that the nail fits through the box. So you need some planning. Otherwise, the old adage of piss poor planning leads to piss poor performance really comes through in these sorts of operations. And this is the other issue that I was alluding to, because sometimes the box, it's not quite set up at the ideal entry point. So often it creates a tendency to have an apex posterior and also some valgus. So just be aware of the little variations in where the box sits related to the anatomical axis of the femur. So this is a little bit more comminuted, and we have a few issues like we mentioned before. There's some diabetes, dementia, ischemic heart disease on anticoagulation, pacemakers, chronic kidney disease. On the whole, if I'm going to be doing internal fixation of these distal femoral fractures, I do not wait until the anticoagulation is reversed. I take the same view that the United Kingdom has been espousing for a long time for fractured neck of femurs, and I push on and I do the operation, obviously mindful that there may be some bleeding, explaining the issue, but I don't wait for the anticoagulation to wear off before I fix these sorts of fractures, because I know that I should be able to fix this sort of fracture rather than do anything more major. And there's a plate, but this is a challenge. This isn't my case, actually, but I'll present it to you because this is at 3 months. And what do we all think? Has it been a good operation? Perhaps the alignment's not as good as it should be. There's a little bit of metaphyseal comminution. We've got unicortical screws, so that's an older case. I was going to mention in this sort of operation, we're not doing an operation like the picture on our left. We're doing more of a minimally invasive procedure, a more soft tissue preserving procedure. And at 10 months, when there's increased pain, there's a challenge here and you need to intervene. Because when you have pain, the pain, as Noratep suggested, sometimes it's related to a loose prosthesis. Other times it's related to a fracture that hasn't united. And you need to make up your mind. This one is a fracture that hasn't united. I don't have the longer term follow-up of that. But here's a great case that I found that teaches this point. Here's a fracture through the plate. You can see that it's a mal-reduced fracture. You can see that it's malaligned. You can see that the biology is probably okay and there's a few medical issues. And this is revised. When it's revised, it's still malaligned. It's not quite fixed well, both in the coronal and the sagittal planes. So it's not surprising that it fails a second time. And, and this is an example which one of my colleagues overseas in North America gave me, where they talked about the U fixation, where they use a cortical bone graft on the other side. I think this was Mark's case from California. But, you don't have to use a cortical strut on the other side. You can use a cortical strut for some extra fixation. But now we're doing plate, and plate nail combinations to provide similar levels of stability. And there's some data which you'll hear about later. And I suspect that you'll hear from Mark about them as well, in terms of the different elements of plate combinations. Now, plate-plate combinations, this is a paper out of Korea. Plate-plate combinations, I think, is a great idea. And, CW may talk a little bit about that in the tibia as well. But I think initially in North America, it was an attempt to provide good alignment and to minimize malalignment or early failure in the fractures. But as we've come to understand in, old osteoporotic bones where there is a significant force at the fracture site, a plate-plate combination or a plate-nail combination permits early weight bearing. And I think that's the key. Since we want them to be early weight bearing, I think these plate-plate and plate-nail combinations will come into their own. Now, I would suggest if you're doing a plate-plate combination, you don't just put a mini plate, which was an old reduction plate technique that they used to put on the opposite side of the femur, but you put on a decently sized plate that allows immediate weight bearing and provides some support. And the same with a plate-nail combination here. I think they're good techniques for early weight bearing. And I agree with Noratep. Noratep talked about, the amount of overlap. I think they should overlap a lot. They should overlap completely, and they should overlap by at least 2 cortical diameters, and and preferably the whole bone. So in order to try and minimize stress rises at the tips of prostheses. Here's another sort of fracture here that's even lower. This is a bit of a challenge. There's a nail. Now, I have real issues with this nail because there's not a whole lot of bone in order to have some distal fixation. Now, some of the nails do allow you to put a bolt in the bottom end of the nail, an osteoporotic bolt, and that provides you with a little bit more stability. But I still have some challenges related to these. And I think if it wasn't for the nail sitting within the cruciate retaining slot in the prosthesis, combined with the bolt across it, then I think we'd have a lot more failures with these short nails. But they can go on to heal, and you can weight bear them immediately. Now, this is a fellow, he's a 58-year-old who has a very high BMI of 48. He's diabetic, hypertensive. He's had trauma in the past. You can see he's had his acetabulum fixed. You can see he's had a knee replacement. You can see he's had a hip replacement. And he's come along with this fracture after being told that he needed an amputation. And he was a big unit. So we thought about it and thought, wow, this is challenging. It would be challenging for him to have an amputation as well because, a man with a BMI of 48 would have really high energy needs, particularly if he's diabetic and hypertensive. And he probably wouldn't be the 100-meter sprinter that he thought he would when he came to see me if he'd gone through with his amputation. So we had a look. It was pretty mushy, the bone at the bottom, but we thought there may be enough bone to get a few screws through. So then we used one of the VA plates. I think the VA plates do have a place, particularly in these very low fractures, because they allow you to angle the screws in order to capture as much of that distal bone. And I pray for a little bit of extra cement when this knee replacement's being fixed, because if I can drill through a little bit of cement and I can get a screw through it, then that provides one extra fixation point. And that, even though it was a very comminuted fracture, he went on to heal, and he wasn't walking without a mild limp, but he was walking around with his leg, and he went back to smoking his recreational medication and having a good time in life. But the key was really using the approach on the left, which was minimally invasive, rather than the one on the right, which is really quite extensive in its approach. Now, this is a great case. I think this is a colleague's case, but I thought I'd share it with you because everyone's interested in mega prostheses. This is a real challenge. This is almost like an elbow that has a similar situation, but chronic kidney disease, rheumatoid arthritis, vascular disease, very hard to fix. You could fix this as unicondylar and you could apply a plate, but could you weight bear him? Probably not, because you can see there's a whole lot of loosening around the mantle. So these are the sorts of ones that sometimes with judicious effort go on to knee replacements with a mega prosthesis. However, we do have skin healing issues, and this skin healing issue is from one of my cases with a mega prosthesis, and it starts off small where you think, I think it'll be all right. Then it goes on to a debridement with a vac dressing, and then it goes on to a flap. And, so old people with vascular disease that are immunocompromised, they do have skin issues. They have healing issues, particularly if we're doing mega prostheses for trauma. And you can have some unexpected outcomes here, which take a long time to heal and take up a long part of their life. But it did heal in the end. So here's another one, fall at home, cleaning curtains at 2 a.m, osteoporotic, looks pretty easy. What do we think of that? That's sort of mixed messages. It's a little bit of absolute stability and a little bit of relative stability. So that's a confusion of principles. Remember we said long and strong, and obviously relative stability rather than absolute stability. So it didn't fail at the point that it was fixed. It failed a little higher again because it wasn't long enough. And then the nail, and I think a nail's a good salvage when you've got a big plate on the side. So don't forget it as a good salvage situation. And if you can get a cross bolt through the plate into the nail, then you'll get a lot of kudos when you go to your x-ray meeting. Now, this I thought I'd mention for more completeness than anything else. In very, very sick people, I haven't done this, but it has been described as this nail cementoplasty where, the bone's terrible, the quality's terrible, the patient's very unwell. So you fill the canal with cement and you put a nail down the middle of it, and that's called a nail cementoplasty. So something to keep up your sleeve in those situations where there isn't much that can be done. And this is the final one. I think Noratep touched upon this as well, but these are the interprosthetic fractures, right? And I think the interprosthetic fractures, is this a femoral fracture? Is this a periprosthetic fracture, a type C of the femur? Or is this a fracture of the knee? It's hard to tell. But at the end of the day, I think we need to do them through Mio techniques. And anywhere along there, I think long and strong. And you can see this plate goes all the way from the top to the bottom. And you have to be careful with these plates. They often have a flare at one side, but you may need to flare the other side a little bit or bend it because you have 2 flares if you're going from the top to the bottom. Otherwise, particularly in old people with poor soft tissues, you'll put a lot of pressure on their vastus lateralis and they'll be quite prominent. You can almost see the plate in some of the skinnier patients that's sitting off the bone. And it's very hard to convince them that, it's a locking plate, it's okay, it'll heal, when they can feel that going up and down and they're very uncomfortable. So I'll leave this case alone. This is an infection case. We'll talk about those later. So I think open reductions are important judiciously. Soft tissue preserving is important and judicious. Bridge plating or relative stability with locking plates, I think, is the key element. And megaprostheses with care. Thank you very much.
There are a number of questions. Marini, for you.
Yep, not a problem. Is it Anup or Jamal? Happy to take them.
When do we decide if we need to do a plate or a plate-bone combination instead of a single plate?
Yeah, I think if the bone quality is a little dubious, if the fracture's a little lower, I think if there's a degree of comminution on the opposite side, I think they're great cases to have dual fixation, whatever that dual fixation may be. That dual fixation may be a plate, a plate nail, if it's a CR, a cruciate retaining prosthesis, or a plate allograft. I think the plates are probably better than a plate allograft, but either or it works.
There's another question. Does using polar screws prevent varus malalignment?
Yeah, look, I think it's tough. So with nails, yes, I think polar screws are good. Not always, though, because what you find, particularly in a distal metaphysis, and I'm sure all the faculty will agree, you put the drill bit in to try and create a polar screw, and then you grab the drill bit and it's moving about. So even though you think you're putting a polar screw in place, the bone quality is very challenging and it doesn't hold the polar screw. So I think you have to be more attentive to reduction. Your polar screw won't provide as much of a counterforce to deformity as in the younger patients.
Thank you. Now, Sokchan, can we go to the next talk, please?
Yes, my pleasure.
Thank you very much.
It's my pleasure to introduce Dr. Chang, who's an internationally acclaimed trauma surgeon. He is a chief of orthopedics at the School of Medicine at Kyungpook National University Hospital, Daegu, South Korea. He is also the current chair of AO Trauma in Asia Pacific. Let's welcome Dr. Chang.
Thank you. Thank you very much for your nice introduction, and happy to join this excellent seminar. And my topic is about tibia fractures after total knee replacement. I will start one of the case that I received from other hospital. This is the segmental tibia fracture after TKL. And there are many options that we can choose, from conservative to the nail X-fix plating. And this is their selection, and they have two plates, one on the proximal on the lateral plate and the other on the medial plate on the distally. And do you think is it stable? So they had two bicortical screws and the three short screws on the proximal side, and then they fixed it with an open manner. And, not surprisingly, this patient had a metal failure, and this is the breakage at the proximal area. And what can be our solution at this moment? But they chose cast because the patient did not want more surgery. But this conservative manner, we usually have worse outcomes when the poor bone quality and in like older age patients. And another 3 months later, this patient visited our clinic, and you see that red skin, and the bone scan shows the hard uptake on the proximal side, and we suspect that is the infection. And we definitely found the infection and in the this non-union site, and we had the infection control with the antibiotic cement. And after 3 times of infection control, we had dual plating on the medial and lateral side on the proximal side, and we also changed the distal plate. And this is 2 years later. So luckily, we had a good healing in this, the failed case in this old age patient. So periprosthetic tibia fractures are difficult to treat, as you just saw that we have a high risk of non-union and reoperation. The contents in this talk is what are the difficulties treating the periprosthetic tibia fractures, and what are our options and factors to consider to make the plan, and what are the common mistakes to fail, and how to make a successful healing. Comparing to the previous talk about femur fracture, tibia periprosthetic fracture is extremely uncommon, and there are two the instances. One is in old age with a TKL with osteoporosis. The other is a young age with a tumor prosthesis. And difficulties in tibia periprosthetic fractures are, the patients are very old, and they usually have a comorbidities, and thin skin of the older patient. Usually, we have a easily damaged condition such as infection or soft tissue problem. And another difficulties are the osteoporosis and osteopenia around the prosthesis, and we have a very limited space to fix, and we have a limitation in the implant choice. This is another case. It looks simple because although it is a periprosthetic, it is a distal tibia fractures. So what can be your options? Nail, X-fix, plate. And in the literature, there are some choices to use the nail. So I think this is one of the ideal option to use the IM nail, but it is limited only in the non-cemented TKL and the short stem of the tibial tray, but it has a risk of a cortical breakage and the malalignment. And how about this one? This Felix type 2, we have a very limited space. Then someone may choose the circular external fixator to have a safe pin entry and the fixation. In this case, in the literature, they chose the Elizarov fixator, and 3 months later, they could remove X-fix. But, we know that this is very difficult for patient because it usually takes a long time to wear, and pin trap infection or deep infection, and certainly we may have some the LOM of a knee joint motion. So how about in this case? The distal tibia fractures, they chose the open reduction and plating with the leg screws. But this open reduction and with the plate, we know that it has a high risk of a wound problem with the non-union and the soft tissue stripping, and then they changed it into the X-fix, and then another 3 months later, they had a cast for this patient, and luckily, the fracture was healed, and the patient visited our clinic, and we found that he has a chronic infection up to now. And another thing is you see that the rotation of the rotational malalignment in this, the injured leg. That's the problem of, the external fixator. This is my case that I had, about several years ago, similar type 3 fracture. And we had a fibula fixation as well as the plate, but the fixation technique was a minimal invasive technique. And then, so we saved the soft tissue to minimize the wound complication. And then we have a locking plate to have enough stability. And then this is about 1 year later, and the MIPO could make another successful healing in this type 3 fractures. So we already reported a successful outcome with the MIPO is quietly, the good option in the periprosthetic tibia fractures. So after TKL, we have two kinds of periprosthetic fractures. So one is a femur and the other is a tibia. So comparing the space for the fixation, the tibia is very limited compared to the femur. The considering factors to choose the treatment is one is the stability as well as like other the fractures, and the other is a kind of prosthesis. And the most important thing is the fracture location or classification. That means the distance from the tibial stem. So usually it is very important to find that whether the implant is loose or stable. So as in this report, if you see that osteolysis, I think it is very reasonable to revise the TKL. In this case, so the patient had the type 2 fracture, but you see that the very stable component, although it is more than 10 years, she received the TKL. And then we had a MIPO on the lateral side. But you see that there are limited screws on the proximal side. Then we need to have the medial MIPO to fix the screws on the proximal side to have additional stability. And then this is a dual plating with a MIPO technique. And this is 9 months later, so nicely healed with this technique and without the soft tissue problems. The kinds of the tibial prosthesis, that is really matter. So there are two kinds of prosthesis. One is a tibial tray and the other is a long stem. Well, it has a different space, and the larger space is we can have a larger space to fix with a long tibial stem. And this is a short stem and another type 2 fractures. And because of a limited space, we had a MIPO on the lateral side and another plate on the medial side with the same technique of a minimal invasive technique. And this is a post-op, and this is 1 year later. Although the patient is a rheumatoid arthritis, but she could achieve the successful outcome of the range of motion as well as the soft tissue healing. Another case, the TKL after, osteosarcoma, and this is a type 3. So we have enough space in the distal side as well as the proximal side. And there are some cement area in between. So we had a lateral nipple. So in this young lady, so we have 5 short screws as well as 1 long screw in the proximal. So then we satisfied with a single plating. So I think it may work in the fracture with the long stem of the tibia. And this is another 1-year follow-up. And she wanted to remove the implant, but we see that there is a good healing at the fracture site. Fracture location is quite important. So this is a quite old classification from Felix, but it is still work. So type 1 is around the plateau. Type 2 is adjacent to stem. Type 3 is distal to prosthesis. And type 4 is a tibial tubercle. But, most of the tibial periprosthetic fracture is type 2 and type 3. But in their reports, the usual principle of a tibial fracture treatment works, but we don't know yet. In type 3, so as I showed in several cases, that we have enough space for the proximal fixation. Probably plate fixation is quite a good option, either medial or lateral. Right, but there are the various range of type 3, according to the distance from the tibial stem. How about this case? 80 years old man, open grade 3B fracture, type 3. So the fracture is not difficult, but the soft tissue problem is important. And with the debridement and the aspects at the first moment, and day 4. So since the medial soft tissue is okay, so we had a MIPO on the medial side with the infection control. And day 14, we had, bone soft tissue defect, and I did the soleus transposition as well as, the back. And we had a skin graft at 2 months. And this is another 1 year later. And, luckily, we saved the fracture as well as the soft tissue in this patient. How about this one? This is a very short type 3 fracture and severe swelling. So this is something difficult in the type 3 fractures. And 2 weeks later, after soft tissue swelling is gone, and we had a MIPO on the lateral side, but, limited the numbers of screws in the proximal side. So we did the MIPO on medial, and the dual plating was done with the MIPO technique. And this is another 1 year later, and she could have a good healing of the bone as well as the soft tissue with this technique. Another type 3 fracture with a long stem. So we can think about in a single plate or dual plate, but if it is a single plate, it is good, but we need to decide whether lateral or medial. In AP view, it is not easy to decide that, but on the lateral view, so there is a little space on posterior, but a larger space on anterior. So then this is quite important to decide that, where is the plate. So we put the plate on the medial side, and then after joystick reduction, and then we could fix 4 bicortical locking screws on the medial side. So that's enough. So we don't have to, dual plating in this case. And this is 5 months later. It's nicely healed, with this single plating. So in type 2 fracture, so we have a more limited space at the proximal segment. So single plate may result in the weak stability. So I think that the dual or double plate fixation is required. So this is another case from my friend from KC Park, and type 2 fracture. So wound care at the first moment, and then he had a MIPO on the lateral side. So alignment is okay, but unfortunately, 4 months later, the implant failure. So why? So what happened to here is, limited numbers of a screw with a weak stability that made this failure, and short working length in the proximal side is that was a problem. So they did dual plating with a bone graft, and later healed nicely in this revision. So similar case in my clinic is I have this type 2 fracture, very limited space on the proximal, the after soft tissue healing, and lateral MIPO was done at first, but I could fix only short screws on the proximal side. So then the MIPO on the medial side was done to add more screws on the proximal side, and this is a post-op. So we could achieve sufficient proximal stability at best. And this is 1 year later, so nicely healed in this case. Another type 2 fracture with a long stem and the clamp assisted reduction, and then put the medial plate, but only 2 screws. That may be not sufficient. So I did another lateral plate to add, the proximal stability. So the dual locking plating with the MIPO technique. So this is a nicely walking lady with the dual plate fixation. So her range of motion is quite nice with a good walking ability, and this is her motion. So this is my summary slide. So in tibia periprosthetic fracture, so limited space of a proximal segment, that is quite important. We need to overcome. Stable fixation of a proximal segment is important. In Felix type 2 or proximal type 3 fractures, so we need to fix dual plating. Thank you very much.
Thank you, Dr. O, for the great talk. There's a couple of questions.
Yes.
One of the question is, which is better, stainless steel plate or titanium plate for fixing these fractures?
The implant maybe, the kinds of implant may be, not important. So I do not have a stainless plate in Korea, only titanium plate. So that can be answered. So that it does not matter. Okay. So, but for me, I think it is important to have, the sufficient fixation in the proximal side. Okay. Stability is more important.
Okay. Another question is, I think earlier on in the talk, you showed a picture where you had a nail for the tibia fracture. Was this done through the conventional technique or through the suprapatellar technique?
Nail. Yeah, that is nailing case was not mine, but that is from the literature. So that is a conventional technique, not the suprapatellar nailing. So that is quite challenging because you need to have a flexion, and I didn't do that any case of a nailing in the tibia periprosthetic fractures using the nail. But since the bone is very weak, I think it is very challenging, to escape from another complication with cortical perforations, and it's an ideal option, but it's very difficult from my opinion.
Thank you. Next, I'll hand it back to Dr. Aslina to introduce the next speaker.
Thanks, Sokchan. Our next speaker is Dr. Dhaval Desai, who is a renowned trauma surgeon working in Vadodara, India. He's passionate about teaching and is a member of the regional education team of AO Trauma Asia Pacific. I hand over to him to give his talk on periprosthetic fractures in a loose stem of THR. Dr. Dhaval.
Yeah, thank you, Aslina, and APOA team. Apologies, can you hear me, everybody?
Yes.
Okay,
yep,
sorry.
Can hear you.
Yeah.
Sincere
you can share your screen now.
sincere apologies for being a little late. I got stuck up in a very urgent family issue, so I'm back here. Thank you for the patience, and here we go. Yeah, okay. So I think periprosthetic fractures are something that is going to be multiplying in numbers in the Asia Pacific, and especially in countries like ours with a huge population and people living just too long. And then the advent of arthroplasty being so well accepted for fractures around the hip at all age groups, and therefore more the operations and more the patient living longer, more the problems coming up at the later date for the younger surgeons. So everyone has an idea about the Venture classification, and I think the challenge comes in tackling periprosthetic fractures when the stem is known to be loose, or the stem, well, it could be expected to be loose, or you also have a bone that's not supporting around that. So that's like a worse scenario. And then we see all sorts of permutations and combinations amongst patients. So I'm going to share a few cases and some thoughts that I have on this problem. I think everyone knows that the challenges for periprosthetic fracture is that it is seldom that we have a best combination of a trauma surgeon and an arthroplasty surgeon. So you probably have the best of half, but I think a periprosthetic fractures need the best shot of both of them happening. On the bad side or the flip side, I think these fractures have definitely higher mortality. So once you get a periprosthetic fracture, this patient has a higher rate of dying in the next few years. And then the risks of complications. So everything is not going to be happy. Almost 50% of these patients, and especially in patients that have a loose stem, you expect that this patient will not have the safe journey along the road. So this much needs to be remembered. And we'll focus our attention on the B2 and the B3, but then sometimes even with a C fracture, you must think that you must make sure that the stem up there is definitely well fixed. So I think you need to keep this at the back of the mind, whether the stem is well fixed, loose or not. Okay. And as we know with revision, so more the surgeries and more number of surgeries the patient has, the chances of a fracture and a stem that is not surviving subsequently is there. And then associated osteoporosis along adds to the problem. So the goals of treatment, you left with two basic choices with a stem that is a B2 or a B3 is A, whether you can just fix the fracture and come out, which is an easier option, maybe sometimes an option in older, sicker, fragile patients, but always not the best option. And your preferred thing would be to revise the stem because the stem needs to be fixed to survive longer. Patients will live another decade or more after this thing happening in his life, and then fixing the fracture. So I think you need to then have the best shot of both happening around there. And you need to get these patients out of bed. You need early mobilization. You need a pain-free hip for these patients. You need a fracture that's well reduced. It's stable. The prosthesis and the fracture are well anatomically aligned, biomechanics restored. And then the last thing that everyone hopes for is that the longevity or the durability. So what you do should last out for the patient's lifetime, which is a hope, okay, and hope for the best for every case. And therefore we do everything that's possible to achieve these goals. Patient who has a periprosthetic fracture and patient who has a fracture with a loosened stem, one would expect a deterioration in his overall function over a period of time. So I think some of these patients land up with poorer ambulation, though they have a surviving implant. They may not walk out as best as is possible. So this was a periprosthetic fracture for a proximal femoral replacement. I think the choice was not perfect, but in this situation, a nail would have been better. And then you have the challenges of in these patients of a fracture, proximal that's comminuted, that's complex, and that needs stabilization adequately with adequate length. You have distal cement block, which is sometimes challenging because that needs to come off or to get a stem length that's adequately long fixing distally, which is often the choice in these patients of a distal fixed stem. And then the anatomy of the femur precludes some of the problems or challenges of, so the straight stems always have the problem when you get longer lengths. You need modified stems in order to get good, adequate, and when you go for long length. So this fracture wasn't, though bridged well and longer, but not adequately stabilized, some cement remaining in. Eventually a 3 years fracture united. But this lady from who was a well, she was able to go out of the house, now is a home ambulator. So definitely a drop in her function. Okay. So what are the challenges of fractures that are in the loose stem? And the assessment is the most important thing. And assessment means that you need to get a good quality radiographs that are able to assess the stems at different levels and in different views and planes to make sure that, there is, if it looks fixed, it should be ensured that it is fixed. And there are otherwise there are areas where it is doubtful, and this needs to be then reevaluated with larger, more better imaging like a CT scan. And sometimes the decision can change on the table. So I think in your planning and your thought process, there should be a plan C and a D or an E for these fractures, where things may change out on table than what you expect around. So you need larger, bigger preparation, but you also need that, an exchanging and an implant and fixing a fracture means a lot of jugglery that you want to play around with, okay, and double the sets of armamentarium. Good imaging, CT scans at various levels will definitely help you to plan out and assess your fracture better. That's essential. Without this information, one should not venture around. And with these, it's important to bypass adequately a sufficient stem width length distally. And then therefore, most of the fixations are distal fixations with stems that are fluted and tapered. And then you must then have methods to stabilize the fractures. And the armamentarium will vary depending on the fracture patterns and also on the local geometry and conditions. And then sometimes you need to augment this with struts or cables if the bone quality is poor. So whenever necessary, grafting and should be added to fill up gaps in the fractures. Okay. What's the best time for surgery for these fractures? Certainly not in the emergency. Certainly not without adequate preparation. Evidence does not support, but it says that maybe you should a delay of 48 hours for good preparation, I think would be very adequate, because everything is not available over the shelf in some of these cases. And every case is unique because there are always something or the other, and then there are some hidden challenges. So I think you have to think 500% before you get into these fractures. Okay. That also includes older patients with medical comorbidities and the need for, adequate blood and backups and everything. So I think you need to be more prepared for these patients. And, we must gather every information that is possible. You also should have a backup of an arthroplasty or a good trauma surgeon along with these cases. So if you think you're a good trauma surgeon, but you're not the best arthroplasty surgeon, and the case is complex, it's always necessary that somebody should be available for an advice, or if necessary, for a backup on the table. Most of us prefer uncemented stems, but the uncemented stems over the age of 75 in these revisions have a higher risk of complications. And I think in some of these patients, a cemented stem would work better for early quick ambulation of these patients. But on the whole, we would end up using a distal fixation fluted stem with the options of modularity in order to measure or get lengths and everything else balanced. Okay. So I think the advantage of distal getting a good fit and a rotational stability with this distal fixation fluted stem is advantageous. The Wagner type being one of those which is preferred. And then you bank on good bone biology and porous coating to get good ingrowth and fixation for longevity of the stems. Okay. However, between modular and non-modular stems, there is a higher incidence of intraoperative or periprosthetic fractures with the modular stem that is, and therefore now a lot of people are preferring or going back towards non-modular stems for some of these fractures. Okay. So what do you consider in planning a periprosthetic fracture when you revise it full round? So I think the revision includes many things. I think you need to think about the bearing that you are going to use, the previous bearing, whether that contributed to osteolysis, whether that caused the fracture. So you want to then change the bearing depending on the age of the patient. For the younger patient, you want a bearing that will go longer, like ceramic or a ceramic with a good quality cross-link poly. And with an older patient, you may then go down towards metal on a poly. You need to tackle the osteolysis wherever there is present. You need to then ensure that the fracture is adequately, the availability of different variable implants that can fix the fracture, as well as a good length stems that can balance the overall fracture stability. So I think you need to have all this available. And very often, very honestly, these are not available on the shelf. So I think sometimes they need to be ordered. Sometimes they might take a while. So, and every instrument company may not have everything available over the shelf. So I think these needs to be taken into consideration. There we go. Previous surgery and implants definitely come in the role and play. Okay. So implants can bother your fixation. So you must have adequate long length X-rays to know that, you could have challenges to fixations. Fortunately, now the industry and research has kept pace to give us implants that can, that have extension, that have got multi-axial, multi-lock options, and then offers variable angles for stability with, with an implant in situ inside the canal. So I think these implants definitely add to your fixation stability when you're revising these stems. Okay. Also remember, sometimes you need to also have good long length plates. And I remember that one of my patients probably needed something like a 380 or a 400, and there was like not available as stands. Even the 400 ended up being a little less short of the lesser trochanter when we had to use this. So VA plates helpful but costlier, and then special periprosthetic plates and cables also need to be present and used whenever adequately in this situation, because you will have the adequate use of cables with bones that are proximally supported by implants and plates. Okay. But the 10-year survival of all these revisions are not fantastic. So this range is around only 70%, and that gets to be kept in mind. Again, taking the right decisions in revising. So, sometimes, I'm sure whether this stem is loose or not loose, and then sometimes you'll end up doing something less adequate, and then you always come back to regret that. So this is a case to share. This was a girdle stone for tuberculosis at the age of 45. She decided to have a revision for this, another after 15 years. Did well for a few years and then started getting distal thigh pain. And as we noted that she had a fracture around the tip of the prosthesis. Okay. Controversy whether the stem was loose or not was always there in the mind. And this periosteal reaction always gave the doubt that there was possibly suspected infection. Ultimately revised by someone with a long plate, okay, with cables. She developed this fracture, but then the story did not end over here. So this is again, the prosthesis is sinking further down, as you see, with the screw backing out, and this story is probably not. So she again came back at 2 or 3 years with pain happening around the line. So as we said before that whether we should have revised this stem or not revise the stem, and this stem was actually it wasn't changed, was supposed to be changed. I think this comes out that if the stem's not well fixed, then it will come back to hit you back again at longer time. Okay. Good planning, as I said, essential. Previous implants, knowledge of previous implants, their extraction. So I think these are 5 surgeries sometimes all into one. And restoration of biomechanics, especially fixing trochanters or fixing, maintaining the offset and length, and all that needs to be taken into good planning and consideration when you're revising. And then last but not the least, there's always the surprise of infection. So always keep at the back of the mind that because this is multiple surgeries, you could land up with getting intraoperative. So intraoperative aspiration cultures, preoperative aspiration preferably. And then you sometimes land up with a situation that is not retriable. So this case, there was a spacer left in with an intraoperative fracture. And then this patient came up for revision after 4 or 5 years. So again, these are like hugely challenging cases. Okay. Even with best of best, you should always think about, so this was a 10-year-old revision for a cemented prosthesis. The acetabulum was worn off significantly, and that was a difficult reconstruction. Initial thought that the stem would be fitting well. Stem came out loose, and we thought that this would be a stem-in-stem revision. We could get the proximal cement out well, and we could get a small size trial in. Unfortunately, intraoperative fracture. So I think this surprise is, so getting an intraoperative fracture is always a problem or a challenge. I think with cement in the canals, and if you want to put in stems or even you want to put in longer stems, removal of cement is a big challenge. I think it's a challenge also with the fractures. So even if you got a fracture, you got cement that's stuck to the walls. And it can be a difficult job to get out all that cement out, because once this fracture happened and we reduced, we really had to get all the cement out that was well fixed to the inner surface of the femur. And that is otherwise not possible to then ream adequately, get the length across very well. And it's an essential part of the game. So unless you take all the cement out very well, you will still not land up getting the best size possible around that. And then again, the issue was this was an issue with the current crisis of corona. All the stem sizes are not coming. So we had a little higher size available, and then we had to really ream it adequately well to get a good fit around. So there are many things that can go wrong, and one must be always be prepared when revising these prostheses or stem. Okay. Always think in mind that will this be the last surgery in the patient's mind, or will this come up around the back with you? So this was bilateral revision done at 10 years after the first surgery, second revision at another 15 years. And then the patient still has, I think another at 5 years, still has now both sides, impending problems and fractures happening around. So I think you hope for that your revision for this B2, B3 fracture is hopefully your last in your follow-up with this patient, but that always does not happen. Okay. Some challenges also with fracture fixations. Okay, adequate bridging principles used, and then sometimes if you follow closely the stem, you will see that this fracture failed in this thing. The stems also kind of moved or migrated. So this was definitely a stem that needed revision. Finally revised, but some degree of varus. So not getting a varus with the stem is very essential. Okay, so biological healing, very important, getting bone replaced by bone and not getting varus. Okay, relative stability very often is preferred. You get a large intramedullary implant, and then wherever necessary, support with a medial strut graft and a lateral tension band. Okay. Sometimes you need to recreate so principles involve creating the tube or the tunnel to get your stem well reduced and fixed in, then, protecting the biology, and then, using augmentation with cables, with bone medial constructs, and then, then getting adequate stems and fixation across. So I think these are hugely challenging cases which are like worth, they need a lot of effort and planning in order to get your outcome well. So, this case, if you see, a lot has gone in, a lot in the form of economically effort, planning, and around to get a good outcome with this patient. And then when you're faced...
I'm sorry, you have about 2 minutes left.
Okay, very quickly. So finally, you're left with huger challenges of constructing bone losses, and there are options available, but these are like expert level areas. Okay. And so finally, just remember that, bone is beautiful, but bone needs to be, don't decorate bone with more implants. Always address the pathology overall. So if there's a loose stem, you better revise it instead of waiting for it to fail the previous day. Don't accept substandard treatments. And I think go out of the case with a peaceful sleep, So do your best at the first time to make sure that, you don't regret to come back the other day. Okay. Okay, I think, so in summary, these are challenging problems that need adequate planning. I think we have not seen the last of these probably. So I think we will see bigger and bigger challenging cases. I think it will be an epidemic of periprosthetic fractures with looser stem that we need revisions. And these are the challenges that probably most of us and the younger surgeons are going to be prepared to face this around. So this was a 98-year-old who came with bilateral fractures needing revision. That's almost an impossible problem to sort out. Thank you.
Thank you, Dr. Dhaval. In the interest of time, I invite Dr. Anup to introduce our last speaker for this session.
Thank you, Aslina. So we have Dr. Sean O'Brien. He's a consultant knee surgeon at Sunderland Royal Hospital, UK. He's also the chair of AO Advances courses in the UK and faculty on the AO Advanced course in Davos. Welcome, Dr. Sean.
Hello there. Hi. Can everyone hear me okay?
Yeah.
Yeah, great. Well, thank you very much for the invite. It's a great pleasure, a great privilege to be asked to speak to you, your society. It's always a worry, though, when you're the final talk in a seminar or a webinar, that everything might be covered by everyone else, and everyone else might completely disagree with everything that you're going to say, and you're left with a lot of egg on your face. Fortunately, with a bit of luck, that might not be the case. As said in the introduction, I just want to move this on. I'm a consultant orthopaedic surgeon working in Sunderland Royal Hospital. I've got a lot to do with AO, both in the UK and internationally on the Davos course, where I've met quite a few of you over the years. I've got no financial or commercial disclaimers. I'm not a professor. I'm not a researcher. I'm very, very much a jobbing orthopedic surgeon, and a lot of what I'm going to talk to you about really are just a distillation of 20 years of practice and what I've learned through trial and error over the years. As I said, I work at South Tyneside and Sunderland NHS Trust, which is very much in the northeast of England, very close to Newcastle. It's a beautiful area. As you can see from the picture below on the screen, it's not dissimilar to the coastline just south of Melbourne and the Great Ocean Road. But it was a very, very industrialized area when I was growing up here. This has all changed greatly. The shipyards have closed, the mines have closed, the football teams have got even worse than they were previously. And the only thing we've got, one of the great things we've got is one huge, great big Nissan car factory, which basically employs the vast majority of people. So you guys from Asia, whatever you do not close down Nissan, otherwise everybody in the northeast of England will be unemployed. So my main area of interest is both trauma and knee surgery. So this is the sort of case that I get asked to do quite regularly in my institution, because I'm the one that takes on the sort of complex knees. So as we've already alluded to earlier on in this webinar, this is a very, very important subject. And certainly in the UK, we've taken on board that the mortality from periprosthetic fractures of the femur is equal to that of fractures of the neck of femur. And therefore, we should really be managing these using a lot of the same principles that we've adopted over the last few years in the UK with our management of fractured necks of femur. The National Hip Fracture Database was launched in 2007. And as a result of this, it's really driven up the quality of care that we offer to our elderly patients, especially those who come into hospital with a broken hip. And this is the 2019 report. On the front of it is a character that I think has pretty much become famous worldwide, a guy called Captain Tom, who was 99 and at the heart of the pandemic decided that following his hip fracture and fixation, he was going to walk 100 laps of his garden prior to his 100th birthday. And it was a result of what started out as a small challenge, snowballed and ballooned, and he ended up raising somewhere in the region of £48 million for the National Health Service, and ended up getting knighted by the Queen for his services. Unfortunately, he died last month and almost had what was almost the equivalent of a state funeral. But as a result of this, every hospital gets published with a graph and an indicator of how they're doing in the management of their elderly hip fracture patients. And basically, this involves a whole series of assessments that surgery is done promptly within 36 hours of admission. They get an orthogeriatric assessment, they get a nutritional assessment, a delirium assessment, and physiotherapy input. And we get paid by a best practice tariff if we actually manage to achieve these goals. So by doing things better and more expeditiously, we actually get a better tariff from the government for the work that we do. Last year in the BMJ, there was a publication which basically looked at the growing tsunami that's facing us with the fragility fractures around periprosthetic fractures and fixation. And what this looked is the last 5 years, from 2015 onwards, at the new code of M96.5. And basically, this is an ICD-10 code that lets us follow all the fractures of bone following the insertion of an orthopaedic implant, a joint prosthesis, or a bone plate. So it's giving us a much more accurate picture of what is actually happening out there with regard to periprosthetic fractures. And it looked at all patients that were admitted to hospitals in England between April 2015 and December 2018. There was over 13,000 patients with a total of over 18,000 admissions, which, so you can see straight away, often one person was admitted more than once. Nearly 90% of these were emergency admissions rather than elective. And there'd been a 13% year-on-year increase in admissions during that 3-year study period. Now, that might be slightly spurious, in as much as the coders are starting to know about the M96.5 code now and starting to use it more accurately than they possibly did right at the beginning of the study. But what it does show is that the findings are about 2/3 to female to male patients. Open reduction internal fixation is still a commonest surgical procedure performed, revision being the second. 73% of these patients have an operation. Medium length of stay in hospital is 14 nights. And there's an increasing age and comorbidities lead to an increase in the length of stay. Nearly 15% of patients did not return home. And the mortality rate of 4.3% overall and 30-day mortality rate of 3.3 is very, very similar to that which we find for the fracture neck of femur patients. Last year, Faris Haddad published a editorial in the Journal of Bone and Joint, which basically outlined what we should be looking towards doing for our elderly periprosthetic patients. And it basically said that we should be managing these very, very similar to how we manage the fracture necks of femur. In other words, urgent, expeditious surgery, but very, very much in surgery where we can offer specialist equipment specialist assessment, specialist surgery, and have, as we've mentioned in several of these talks, have the ability to perform not only plan A and B, but also plan C and D. The final part of that editorial was very much that we should not be doing things that render the patient still bed-bound or wheelchair-bound. That, it's counterproductive, and our aim of any surgical intervention, any surgical goal, should be to get the patient back up on their feet as quickly as possible. So as a result of this, I looked at my personal 5-year dealings with these patients over the last 5 years. As you can see, I dealt with 48 patients at a mean age of 85. So that age is creeping up all the time. Several in the age group between 90 and 100. Like the paper in the BMJ outlined, vast majority are female compared to male. And the vast majority had some form of open reduction, internal fixation, with the next commonest being a revision. And as Marinis said, I still do use intramedullary nails in a few but well-selected patients. I think they're very useful if you can choose the right patient. So what are your treatment goals? Your treatment goals have got to be to offer a modality of treatment that's going to give the patient the best chance of returning home and mobilizing independently as quickly as possible. And there are things that can help us with this. We've already seen the Vancouver classification helps us achieve these treatment goals. There's the Lewis and Rohrabeck for the distal femur, and there's the Felix and the Stewart for the proximal tibia. And they've all been gone through in great detail in the previous talks. There's also now a new classification, which is based around the AO system for the periprosthetic fractures associated with total knee arthroplasty, splitting people up into A, B, C, D, E, and F. This was published in 2016. And if you've got an interest in this subject, it's worthwhile going and looking at this in a little bit more detail. So the questions before you take on any of these cases, you've got to ask yourself are, is the implant still well fixed? Was the patient functioning well prior to the fracture? Can the fracture be reduced and stabilized sufficiently to allow that early weight bearing? And is the patient medically stable enough to undertake the planned procedure that you're proposing? But you've also got to ask yourself a few questions, and that, are you the right person? And is this the best institution to carry out the procedure? There's no loss of face or professional climb down by asking a colleague to take over a case if they are the better person to do it. If they've got the skills and the repertoire that you don't have, that allows them to be able to offer that person the best chance that they have. And try and take some time getting to know the patient. Marvin Tile described the personality of the fracture. It's a phrase I think we've lost the art in sort of looking at a great deal lately. We all get hung up on at our trauma meetings on looking at the x-rays. I always make a big fuss when I'm on call of going to see all the elderly patients before I go to the trauma meeting. So I've got some idea of what their functional capabilities are, as well as what fracture they've got. Every day in our institution, we have an MDT meeting. We have not only the daily trauma meeting, where all the cases that have been admitted the day before are presented to all the registrars and the students, and everybody's grilled, and all orthopedic surgeons have a great time being the A+ personalities that they are. But we also have what we've now coined as a daily Toga meeting. And that basically is the meeting between the trauma surgeon doing the list, the ortho-geriatrician on call, and the consultant anaesthetist doing the list. So every trauma list in our institution is covered by a consultant trauma surgeon and a consultant anaesthetist. But it's the ortho-geriatrician that probably has one of the greatest inputs in this meeting about telling us about what they think the patient's medical condition is like, what they're likely to be able to achieve afterwards, what their rehabilitation goals are going to be. And the adoption of this meeting has, I think, universally improved our outcomes. So what are our treatment options? There's always that option of non-operative management. Very, very rarely used in the periprosthetic fractures. I did actually manage somebody non-operatively a couple of weeks ago who had a distal femoral fracture, whose level of function was extremely low. She had already a fixed flexion deformity and was already wheelchair bound. And it was her that prompted to just go into a brace. So we'll have to wait and see if that has united. But there's always the surgical options, of which the commonest is open reduction and internal fixation. And it's interesting that I put single or dual locking plates, and I'll go on to this in greater detail, following the talks earlier on. Closed reduction and nailing, the revision megaprosthesis, and then a novel method, which I've used a couple of times and we published in Injury a few years ago, which you can use with a certain type of prosthesis, but not all. There's a phrase that's bandied about in the UK and in the NHS now called get it right first time. In other words, you have one shot at most procedures. You have one attempt at getting this right. And you see this is a very elderly person with what appears to be a nasty distal femoral fracture above a knee replacement that appears to be well fixed. I think most of us would probably plan for open reduction internal fixation as the treatment modality for this particular person. However, you can't rely purely on a plate to do all the work for you. You've still got to have the same AO principles that we've always had. And that is, you've got to reduce the fracture. And you've then got to stabilize the fracture using an implant that's strong enough to allow you to achieve your treatment goals of being able to weight bear and mobilize that patient early. And you can see in this case, they've certainly not reduced the fracture. And probably that plate is short, as we've said before. We're now looking at long and strong constructs. It's being asked to do far more work than it can actually achieve. And unfortunately, it failed. Again, here, we've got a 92-year-old person with a fracture that is eminently fixable and eminently will heal. But unfortunately, they asked the plate to do a huge amount of work. It's nicely reduced. It's fixed, long, but it's probably not strong enough. There's an immense working length here. And that's asking that to do a great deal in a 92-year-old who we want to mobilize straight away. And unfortunately, by 6 weeks, we were seeing the failing implant, the fatigue stress on the plate and the plate fracturing, and no real signs of fracture union at that stage. So what did we do? Well, we took the plate out, and as has been mentioned earlier on before, we did a standard anti-grade nail. And this was enough to allow this particular fracture to unite. And 6 months later, we had nice fracture union with a functioning knee replacement below it and the patient up and about and mobilizing. This is a 61, much younger person. Again, good bone stock, a very early fracture in the post-operative period. This was a day after the knee replacement, which I had done. Unfortunately, our anaesthetists still love blocks, and occasionally you get the patient wanting to get out of bed themselves independently, and you're faced with this problem. I think most of us would accept that the bone stock is good, the biology is good. So with good anatomical reduction and a well-placed laterally based plate, this should unite. And you can see 1 year later, you can barely see the fracture on the AP. You can see a little bit of callus on the lateral view. And this person's up and about, moving and mobile, and very happy now with both their knee replacement and has pretty much forgotten about the femoral fracture. This was a 95-year-old lady who had a very functioning knee replacement. It was only about 6 months after the knee replacement that she came in with this extremely low periprosthetic fracture. And I was very reluctant to have to take this out and revise it to a megaprosthesis. So we got a CT scan, which showed us that there's probably just about enough bone to get some purchase at the lower part of this fracture. But again, like we mentioned before, one plate is not going to be strong enough to get a 95-year-old straight up out of bed and mobilizing. So this is very much my preferred method of fixing these in the elderly, and that is the dual plating technique, where the predominant plate is the laterally based locking plate, but I'll slide in a relatively small MIPO medial base plate to act really as a buttress and give that construct the stability that it needs to allow the person to get up and about straight away, back to independent walking, into independent living. And she's done very, very well. This 65-year-old male fell off a ladder, cutting his hedge. And as you can see, this is a more complex, multi-fragmented fracture. But again, there's enough bone distally to think that we should be able to fix it. But I wasn't convinced at all that we'd get enough purchase and enough stability on the construct with just purely a lateral base plate. So again, I went for the dual plate locking option, 2 separate incisions, not the old-fashioned big midline incision. MIPO as much as you possibly can, but keep the incisions well away from each other and preserve that blood supply. This was a lady that came in earlier this year. Now, she's BMI of 52. She's got a grossly arthritic hip that doesn't move at all, and she's been turned down by the anaesthetists on 2 occasions for having a hip replacement because of her comorbidities. This is an emergency situation, and then you do tend to find that the anaesthetist's arm are a little bit more twisted. And I wanted to do something quick for this lady, something that I could get her up and about, mobilizing on, and ability to get her weight bearing. And just as we talked before, some knees you can get an intramedullary nail through the box. And I wasn't particularly certain whether I would achieve this there, but with her just on a standard fracture table with a bolster underneath the knee, my first line was just to see whether I could get that initial guide up through the box of the femur, which we could. We extended the fracture periprosthetically during the iatrogenically during the operation. We got a nice, big, long, stable intramedullary nail through the femur and got her mobilized. The downside to this was she sailed through the operation. She failed her spinal. She ended up having a GA. And now all her husband wants to know is why was she turned down for a hip replacement in the first place when she was perfectly capable of withstanding an operation, and wants the nail taken out once the fracture had healed, and she wants her to have a hip replacement. So that's another challenge that you get when you do things. 85-year-old lady, again, very, very low, very comminuted fracture. CT scan shows that there's multiple fragmentation. And in this situation, I went for an early megaprosthesis. I thought there's no way I'll be able to get stability with this lady to get her up and about and moving and mobile. So we have these on the shelf. They're always there if we can't get fixation. And I'm quite happy to move to this quite quickly in my armamentarium if I need to. Again, 82-year-old PS box implant, not a lot of bone to get any fixation on. And we went straight for the early megaprosthesis with a short stem and an early immediate weight bearing. This was a bit more of a dilemma. This is a much younger person. It probably could have been fixed. It probably could have been stabilized. It's quite a nasty multifragmented fracture. It would have required 2 fairly long plates. We therefore went for the decision for a really long, extended megaprosthesis in her, but we got her up and about, moving and mobile. The downside is she's only 65. She's likely to live for a good 15, possibly 20 more years, if not longer. And somebody else who's a lot younger in their career, I'll probably have to deal with the consequences of what I did with this particular lady. You also got to face that you often have the associated dual implant of the knee and the hip, as in this case. And again, long plates. I appreciate from this talk, I probably not got as long a plate as I should have here, and I should have bypassed the stem of that femur with a far greater length on the plate. Fortunately, it has united, and she is up and about and moving and mobile. Now, I just wanted to talk to you about a technique that I personally developed a few years ago. If I can go backwards, sorry about this. If I can just end the show, I'll just pop back just to that particular one. We're there. This was a lady that came in. She was 84 years of age with a very low periprosthetic fracture of 6 months. It was functioning very nicely in this PFC implant. Now, you can get away with this using a PFC, especially if it's a PS implant. And what I did was I took down the lateral collateral ligament and actually put up just a standard revision TC3 stem. And you can actually attach the TC3 stem onto the box and close the whole construct back up and reattach your lateral collateral ligament to the distal femur. And I suppose a little bit like the cementoplasty that we saw earlier on using a nail, we filled in the gap around it with some bone cement. So the implant's not been taken out. We've just really done a nailing by using the standard TC3 stem that attaches to the PFC as our implant of choice. And this was her 2 years later, post-fracture, when she came in for a review, up and about, mobilizing, straight leg raised, good function, good fixation, and she's doing very well. And we've done this in a couple of cases because we did a lot of PFC implants in our institution over the years. We actually wrote that up in injury. So in summary, what I would definitely say is treat every patient as an individual. Go and see the patient, get to know them, find out what the goals are, find out what the comorbidities are. Involve a full MDT. As I say, fortunately, we have that MDT every single day of the year at the start of the trauma list. Ask yourself, do you have the skills, the equipment, and the backup that's required to do the procedure? Asking a friend to take over or I'll be there to help you out is perfectly acceptable. And the first goal is got to be, you've got to get these patients up. You've got to get these patients weight bearing as soon as possible. So thank you very much. And if any of you ever get the chance to come and visit the Northeast, the industrial landscape has now been replaced by quite a dynamic metropolitan type area. What we can't promise you is warm weather. Thank you.
Thank you, Sean. Azlina, would you like to have questions now?
Yeah, okay. So thanks to all the speakers, great talks all around. We've had quite a number of questions put up in our question board. So there is one, this is for all the faculty. What is your opinion on the use of tensioned multifilament cables?
PW, perhaps if you could start with the tension cables.
Yeah, thank you for the the important question. But so there is some some benefit to have the stability with the tension the wires, but I do not believe that is quietly stable. So usually we need to fix that and get the stability by the the plate and screw or nail. So I usually use a wire or any kind of additional reduction material that is for just reduction. I'm not sure that it is enough stability to have that in this periprosthetic fracture as well as any kind of fracture. But in some case, if we cannot fix the screw, I think that is our final solution to have.
Yeah, I agree, CW. I think, you inevitably, when you go back to do a case, sort of 3, 4, 12 weeks after you've put the cables on, the cables are all loose. So, Noratep, you like twisting some Chanley wires, the old technique,
Yes.
but therefore provisional fixation. What are your thoughts on the cables?
Yes, I don't have a chance to use the cable because it's a little bit too expensive. However, we know that the cable is better than traditional wiring, but as we can see from the biomechanics study, both of these techniques is not strong enough to hold a fracture. So personally, myself, I prefer screws.
Okay. I guess we can move on to the next question. There was one which is personally that I find pretty interesting. Is there any medical treatment that any of you would give post-fixation in the elderly to promote fracture healing?
Okay, I think that for the medication, we know that mostly we provide a supplement, the calcium, the vitamin D for the patient who sustain fractures. For the other medication, I think we know that there are another kinds of medication, the bone forming agent, the teriparatide, which may promote the fracture healing. But I do search on the literatures. We still found the limit of the evidence to prove that it can help us promote healing. Even a simple hip fractures, the evidence is still limited. So I think, it's the option, but based on evidence, is still not able to recommend to give it to into every case. So personally, I just use it in some cases which I found the bone is too fragile with the BMD, which very fragile, less than minus 3.5.
Okay, because it is off-label use, isn't it, if you were to use any of those drugs?
Yes, that's right. It was off-label used.
As Lena, our biggest challenge in Noratep, and Sean could comment on this, when we look at the Australian and New Zealand hip fracture registry, is the number of people, the high proportion of patients that actually are discharged from hospital who are not on bisphosphonate or bone health treatment. And that is a major issue. And I think we almost need to flip that on its head, and that, unless there's a contraindication, every patient that comes in with a neck of femur should go on to calcium and D and bisphosphonate till proven otherwise. I mean, I don't know. What are your thoughts on that?
No, personally, I think, that's true. Go ahead.
Part of the NGR, part of the National Fracture Database sort of set that you get your best practice tariff on, is that every patient is assessed for fragility fractures, and every patient has a bone quality assessment. So pretty much everybody that comes into hospital will go home on a bisphosphonate, a calcium tablet. Everybody in the northeast of England who is over a certain age is now vitamin D deficient, because we just don't see enough sun, and people don't work outside as much. And it is true that they're now looking at vitamin D supplementation for school children, because and the fact they're not getting out enough, they're not out playing on the bikes. We have a long winter where it's dark. You go to school in the dark. You come home from work in the dark. But we also have a fragility fracture team in the hospital, that every single patient that comes to fracture clinic is assessed for has an osteoporosis assessment. So it's something we're pretty hot on.
Okay. Is that the same in India?
Yeah, it's the same almost in India, or you see the Asian country, same in India, that almost 80% of people do have a vitamin D deficiency. So like I also have a protocol that we don't go for checking on the vitamin D levels. We give it for the 3 months and then reassess. So for all the elderly patients, whosoever comes in OPD even for osteoarthritis or any such kind of problems. We do give vitamin D supplementations, make sure that they get it for 3 months. And thereafter, if you feel like, we go for the checking of the levels of vitamin D. But how many of you really use calcitonin in these kind of fractures as a routine, or you pick and choose your patients for use of calcitonin?
No, we don't.
We don't either.
I don't use
good nutrition is the possibly the key, and that's where the OrthoJerry input. Once we've fixed the fracture, our input is very much once, twice weekly ward round to look at the wounds and make certain they're doing okay from the orthopedic side. But it's the orthogeriatricians that take them over, and the orthogeriatric physiotherapists, and they deal with all that. So it's a great sort of MDT input.
Okay, good. And Anup, do you have any other questions or Sokchun?
I just wonder if Noratep or Dhaval can put it on. Did they had any difficulty in putting a long stem of Zimmer or striker, especially in Asian females? Because they're short stature, while you're reaming, there are very fair chances because we get high diameter, the initial diameter in a striker and Zimmer. If you're using a long stem for a weakness.
So Anup, that last case that I showed, which had a fracture on table, that needed a very religious reaming and a lot of clearing of cement to get the diameter in. So I think it's a challenge without any doubt, because I think some of those diameters are not perfectly suited to our bone quality. I think, as I was saying, if you got cement inside the canal, unless you take out especially the distal cement, which is so adherent, even getting a fracture or making an osteotomy make your life easier. You've got to still clear everything out so that you get a whole correct size reamer going down sufficiently enough. So I feel probably revising a cemented stem could be really challenging if you're putting a long fluted stem or any of those long uncemented stems. That could be really hard job.
Thank you.
Okay.
There was a nice question in the chat that I think maybe I can throw this to Noratep to start with, or Dhaval, and both of you could comment. There was a query as to when you use a cross-bolted stem when you're doing a long stem hip replacement. Maybe Noratep first. There are stems that we have that you can actually put cross bolts through the bottom of the stem, Noratep.
Cross bolt, or which means that there is a stem that we put the screw through the stem. Or okay. This is one of the stem, but I didn't have experience to use it. But I think it was one of the options that we can use in periprosthetic fractures. I mean, it should be used as the revision cases, right? Not the well-fixed stems.
Yeah, Dhaval?
I think I don't think there are there are not many available on this, but I think that would really come down to if you don't get a good fit and you got a challenge bone around. So I think that's where you probably use the bolts across. But not the usual exception probably to the rule.
Yeah. So I've used it on a couple of occasions. One is when you just have an absolutely smashed femur and you want to get some fixation at the top and the bottom so it doesn't sink or compress, because otherwise they can concertina sometimes. And the other time I've used it was with one of the questions where there was some fractures right through the middle of the femur, and it's fractured the cement. And then taking out the distally fitted prosthesis, the bottom end of it, we've fractured it a little bit more. So then you need a cross bolt at the bottom to try and keep the length. And sorry, Sean, I caught you out of the corner of my eye, but I'd started talking. Your experience?
No, I think exactly that. It's where you can't, the guys in our place use them when they can't get isthmus fit. If it's not just a straightforward, as you say, revision cement on cement, and they're going for a distal fix, but they can't get an isthmus fit, then they'll use the crossbolt one. I think, is it the ACE nail or something? Or the ACE?
Yeah, we use the Biomet one, the Zimmer one, but I mean, there are a couple of them around in the companies. The Arcos is the one we use.
The Arcos, that's it. That's the name.
क्या हुआ है? Aim से अच्छा.
All right, Anup. So if we, I'll let Anup thank the faculty, and then we can sort of start closing the meeting, and obviously our terrific moderators.
So thank you everyone for joining us. It's really a wonderful academic learning process for all of us. And thank you all the moderators and Marinis for giving this opportunity, and Jamal for organizing all this show. It was really wonderful to have you all here. It was a great deliberation of knowledge and skills. Thank you everyone.
Thank you very much.
Thank you everyone.
Thank you everyone.
Great.
Thank you. Bye-bye.
Thank
you. Next.
Thank you. Bye-bye.
Thank you.
I'll stop this streaming. If you want, you can discuss among yourself. Lakshmi ma'am, shall I end the meeting?
Yeah, Janvi.
Okay, bye ma'am.
Bye.